All right, guys. Thank you all for coming tonight. This is John Howe. He's a doctor based out of Encinitas. He does a practice where he uses techniques that a lot of you might not be aware of or might not have known were available to help manage chronic pain and injuries and even potentially prevent surgeries and things of that nature. So I'm going to leave it to him. So he's the expert. So yeah.
Awesome.
Thank you.
Thanks, Ben. Appreciate it. All right, so yeah, thanks everybody for coming. I appreciate it. Thanks to SmartFit for having me and inviting me. Appreciate that too. Like Ben said, what I'm planning on doing today is talking through a few different options. Some you may have heard of, some you may not have heard of, to help treat pain and dysfunction. There are essentially 5 things that I'm going to talk about, techniques that is. One is called nerve hydrodissection. The next one is called shockwave therapy. PRP injections or regenerative medicine, and then medical massage, which you guys may have heard, probably are familiar with that. So I'm also going to start and talk through when someone comes to see me with pain, with injury, what do I do? How do I think about it? How do I approach it? So it kind of give you a framework to go from there. So the first thing we start with is, why do you have pain? You know, there's a lot of different reasons people may have pain. Sometimes there's a history of an injury. And I did this, I was hit by a car, and ever since then I've had pain. Well, that's pretty obvious. It's probably having to do with whatever the injury is. Sometimes it's an overuse or a wear and tear injury. Having osteoarthritis in the knee or the hip is a pretty good example of that. Sometimes it's a dysfunctional movement pattern. It's a pretty common thing where the thigh muscles, they don't all move together. And so the kneecap gets pulled over to one side chronically, and then that one side of the kneecap will wear out. So the problem is, you have pain down on the knee, but the problem is really with the thigh. And then there can be some sort of systemic underlying condition, an autoimmune condition, a hormone deficiency, a vitamin deficiency that can contribute to why a person is having pain. And sometimes there's no reason at all. Like, I was doing fine, and then all of a sudden I sneezed wrong and my back went out or something silly like that. And that's a pretty common story as well. So the first thing we do is sit down and talk. Why? What's going on? Well, how long has it been there? What are you feeling? Where's your pain? We talk about any kind of prior studies that you've had, XRAs, MRIs, ultrasounds, or evaluations you've seen your doctor, your primary care doctor, orthopedic surgeon, chiropractor, acupuncturist, whoever. A lot of the things that I do have to do with what I can see and treat using an ultrasound machine. I'm an expert in using ultrasound to look at musculoskeletal problems. So muscles, nerves, ligaments, tendons, blood vessels to joints, that type of thing. And so I'll look at wherever the pain is, and then usually we look up and downstream a little bit too, because if you got knee pain, oftentimes it has to do with the thigh, or it can also have to do with the calf. Back pain is also another one. So it's your hip, your upper back can contribute. Using the ultrasound, pushing, trying to figure out what's going on. And then we listen to your ideas. Most people have a theory. I think it's probably this. Sometimes, a lot of times they're right. They say, well, you go see other doctors, they say, well, we did an MRI, we didn't see anything wrong with whatever you think is wrong, but let's look at it again and see if perhaps there is something else that's going on or your theory is correct. And from there, we formulate a plan. So, what are my choices? What I want to know is why you have pain. What is hurting? What is the pain generator? It could be a pinched nerve, it could be a stuck muscle, it could be an inflamed, degenerated joint, it could be a combination of these things, it could be a torn ligament or tendon. And then, like I said, there can be an underlying problem. If your testosterone is chronically low, that's going to make everything hurt. If you have some sort of autoimmune condition like Hashimoto's thyroiditis or some Sjogren's or other things that can contribute to why a person is not feeling well or why they're having pain. I'm going to walk through a few different techniques, like I said earlier, and kind of describe them. I wish I had visuals, and I'll send those to you guys so you can kind of see what I'm talking about. But the first thing I'm going to talk about is a technique called nerve hydrodissection, or ultrasound-guided nerve hydrodissection. Hydro is liquid or fluid, and dissection is to separate. So what I'm doing here is I'm using the ultrasound to guide a needle to a specific spot in the body and injecting fluid to separate structures out. I commonly use this when I'm treating nerves. So sciatica pain is often one of the things that I'll treat with that. The sciatic nerve is the largest nerve in your body, and it comes out of your pelvis right about in the middle of the glute and then runs down the back of your thigh. And there's a muscle that goes right across that nerve called the piriformis muscle. So the nerve is like this, the muscle's like that, and oftentimes that muscle's tight, and the nerve gets stuck to it. So we can go in there and put fluid right around that nerve, and it will release from the muscle, and the pain should decrease. That's just an example. We can do it with carpal tunnel. Excuse me. We can do it with impingements in the elbow. Basically, temples to toes, there's areas where your nerves can get stuck, and we can use this treatment to help address it. The action of injection breaks up the adhesion. So if a nerve has been stuck for months to years or whatever, there are small little adhesions or tissue in the body that is grabbing, sticking one structure to another. We go in there and we break up those adhesions. The fluid stays in the body for about 3 days or so, and it ends up going out in the toilet. But once we've broken up the adhesions are now gone, and they can move. Things can move more normally. This improves pain, decreases numbness, improves strength, and improves movement in the area. So I'm going to try. We'll see. I've got a video that's kind of demonstrative of what I'm trying to. Can you see that? Got a cable? All right. Groovy. We're on. Thank you, sir. I can come back a little bit. Come with me on this, maybe.
Yeah, we might have to take the TV off. It's plugged in for this. Yeah.
I can hold one in if you want to. Carter's got it. I'll get out of your way. Good? Okay. So I was going to show a video, but we'll show it afterward. It's pretty neat because you can actually see the fluid actually separating the layers out. It gives you a real good visual on what we're trying to do. But basically, I'm trying to create space around structures so that they can move more normally. Another place where we'll use this pretty commonly is people that have Achilles tendon injuries. The Achilles tendon is this massive tendon. It's the biggest one in the body, down here by the ankle. And there's really no good blood supply for it. So if someone has an injury to that, the body, part of the healing process is it will grow little blood vessels into the tendon to heal it. Now, the tendon's supposed to slide like this, and you might imagine if you have blood vessels that grow into the tendon, it's tethered now. Now you have a healed tendon, but it's often that it's stiff and it can't move very well even after a surgery. So what we can do is I can see those blood vessels with the ultrasound. There's a part of the ultrasound called Doppler, so I can see flow, I can see blood flow, and I can go in there and without opening the scan, just by using a needle, we can pass the needle back and forth and break up those blood vessels that are sticking the tendon to the other rest of the body or the fat underneath it. And almost immediately, the tendon moves better. And as you might imagine, once it moves better, it's less pain, more function. So just two examples of how we can use hydrodissection. It's probably one of the most powerful things that I do. And I'm biased because I love using it. It's super neat. You can see it. I'm very visual, and I love doing what I do. Say again?
How long has that been a thing? I've never heard of it.
Yeah,
How long have they been doing it?
Yeah, the question is how long has hydrodissection been used? It's sort of a riff on something that we've been using for a long time. When you go to have a surgery, for instance, they're going to do a nerve block. Let's say you're having a shoulder surgery and they're going to put stuff around your brachial plexus. They'll go in there and they'll put a numbing medicine around the nerve to deaden the nerve. So it's exactly the same technique when I'm treating that specific nerve, but you're thinking about it differently. So I'm not trying to, let's say, all right, so I'm looking at the thumb, I'm going to block a nerve up here that gives me sensation in the thumb. So I use that technique by surrounding it with numbing medicine. Now I'm thinking, well, is there a sticking point all the way along here or at any point along here? And I'm going to look for that sticking point and then treat that specific thing. So hard to answer your question because we've been doing it forever. We just are thinking about it differently. And we're using it to free up structures as compared to putting medicine around a nerve.
Yeah. And so how long have you been doing it?
Me, 4 years, 5 years, yeah. Or more. I mean, I've been doing nerve blocks for 15 years, but doing this specific thing to treat musculoskeletal or movement complaints, yeah, about 4 or 5 years. And it's, you can never You always got to learn because it's the whole body and you got to know everything, but it's been a while. All right, so we can come back to that. I'd love to answer more questions about that. The next thing I want to talk about is shockwave therapy. Shockwave devices are medical devices that create acoustic waves that travel through tissue. There's a bunch of different brand names that are out there, but the idea is what we're trying to do is to create small trauma within whatever tissue we're talking about, and it could be either plantar fasciitis or a stuck muscle or something like that that causes regeneration, triggers the healing processes of the body to cause healing to happen in the area that we're using the device on. It can break down scar tissue, it reduces pain, it can break up calcifications. Sometimes as the body's healing, it'll put calcium in stuff. Tendons are a real good example of something that calcium gets built up in. A rotator cuff tendon, for instance, is a very common thing to have calcium in. And as you might imagine, when you move your arm like this, if you got a tendon that has a bunch of calcium crystals in it, as that moves through the body, it doesn't feel very good. So this is one way that we can actually reduce the amount of calcium crystals that are formed, improve function, decrease pain. So it's usually used on muscles or tendons, but there's a lot of different uses. It can be used for erectile dysfunction. It can be used to decrease cellulite. There's a lot of different applications for this type of technology. I primarily use it for treating pain and musculoskeletal stuff, as you might imagine. The other benefit of this, in contradistinction to some of the other things I'm talking about, is that you can use it on an athlete in season. So somebody that is, they're doing whatever it is, they're in track and field and they're not able to take a break from their training, you can use this. There's no downtime. Whereas some of the other things that I have talked about or will talk about, that you have to kind of stop doing whatever sport you're doing for a brief time. Medical massage is the next thing I'm going to talk about. Most of us in here have had a massage. And you probably know there's a big range between massage therapists. Different people, you go to Massage Envy and have an hour, it might feel good, but it doesn't necessarily make your body work better long term. So a medical massage therapist is someone that's had extensive training, knows anatomy really well, uses techniques, deep tissue massage, cupping, different positioning techniques, and works in conjunction with a provider, a physician that knows what's going on, can say, this is the area of the body that we're working on. These are the specific structures that I've worked on, and then I work in close contact with a medical massage therapist at my facility. But we work together. I do what I do, she does what she does, and make people feel better working together. The one thing I would say is not usually a relaxing experience. There aren't like candles and nice scents and stuff like that. The lights are on and we're trying to do a specific thing. So
John,
yeah.
it sounds like are the techniques considerably different in terms of how the person's moving their hands around whatever it is that's damaged or painful?
Usually they focus on a region of the body for the entire time, as compared to going and get a full body massage. And their knowledge of what can contribute to pain and stuck muscles and things like that, both up and downstream. Let's use the shoulder, for example. Going up into the neck, going down into the lats, and working in the pec muscles to try to get all of that moving correctly, and then coaching the patient. Listen, you're slouching like everybody else on the planet that's texting and driving, and stand up straight, do these things, tuck the chin, and can give you additional things, much like a physical therapist can, to do on your own to help with the way that your body is positioned, the way that you're using your body. Yeah. Trigger point injections are the next thing I was going to talk about. So trigger point injections, you may have heard of this. I use the ultrasound to do them. We go into the muscle, and just passing a needle into a muscle that's irritated, stuck, and like say a knot in your neck, oftentimes will cause the muscle to spasm and release. Sometimes people will use steroids in this, to inject steroid or lidocaine into the muscle. I don't usually do that because you don't really need to, and there are some downsides to those things. This can be used in conjunction with, at the same time I'm doing hydrodissection, I'm often doing trigger point injections because the muscles that are stuck are often spastic and not moving. So we'll use a combination of those things. The last treatment I'm going to talk about is kind of a broad category called regenerative medicine. Regenerative medicine is a type of medicine where we're trying to restart the body's ability to regenerate and heal itself in a specific area. An example of this is PRP. PRP is a substance that we take a person's blood. PRP stands for platelet-rich plasma. So I'll take a person's blood and I'll concentrate your platelets Your platelets are the body, the cells in the body that identify where there's a problem. Say I cut myself, the platelets will immediately go there, plug up the hole and say, hey body, we got a problem, we got to fix it. So I will inject those platelets into an area that will trigger the healing response of the body in that specific area, causing remodeling and restructuring of the tissues in that area and healing. It allows us to target the healing properties of the body to a specific area. It tricks the body into restarting the process of fixing a wound. It recruits the stem cells and signaling molecules to the area, decreases pain, and increases function. The other thing that's helpful to have in conjunction to everything I have talked about so far, is safe, effective, adaptive movement habits. And that's some place where SmartFit is really good. These machines that you guys are sitting in next to, there's some that we try to avoid if you have a certain type of problem, but when I have a patient that comes in, I've got plenty of patients who are SmartFit members, I know exactly what they're doing when they come here, and I know that Ben's going to keep an eye on you when you come back and train here. So it's nice to have a combination of good treatments and then also great trainers to keep people safe when they're injured. 2 more points. One is that a combined approach is often best, meaning the different techniques that I spoke about this evening, if you combine them in different ways, that's often when we see the best results. So it's very common for someone to come in and I'll do hydrodissection on them, I'll do a PRP injection on them, and then we'll send them to the massage therapist once a week for a month. Something like that's a pretty common cadence. And then shockwave can be used as well. The one thing I touched on but didn't talk a lot about is functional medicine. If you have an inflammatory condition like a nutrition deficiency or a hormone deficiency or some sort of autoimmune condition, it's often the results that I can get when I work with you are much better if we are addressing that at the same time or it's addressed first. When I opened my clinic, I was only doing the musculoskeletal stuff, and I realized that there's, the same kind of person would come in, I would do the same thing for 2 people. One person would have great results and the other one wouldn't. And it's very frustrating, and I want people to do better. So I started offering functional medicine in different forms, and now I have Adam Silverman working with me, who's a fantastic naturopathic doctor. He gave a talk at the Cardiff location not that long ago. To have him be able to work with the people that have underlying systemic inflammatory conditions has changed my practice significantly. People do a lot better when we're looking at both the rest of the body as well as I have the luxury of coning in on where the pain is and see if I can make the person feel better. All right, so that was it. I was going to say, if you want to get in contact with me, I'm usually at the Cardiff SmartFit 3 days a week from 6:30 to 7. A.M. I might be a little sweaty, but I'd be happy to chat. And then I've got my office phone number and website, and we can hand those out. But any questions, anything come up while I was talking? You already asked a couple, appreciate that.
What is the different medicines that you use for hydrodissection and nerve block? So nerve block, I'm assuming there's some kind of steroid or something like that. What's the different chemicals?
Yeah, it kind of depends. If I'm doing a nerve block to block pain during a procedure, which is not something I routinely do in the clinic, although we do sometimes, we'll use a long-acting anesthetic like ropivacaine, for instance. When I'm doing hydrodissection, the majority of the stuff in the syringe is just 5% dextrose, so sugar water, effectively. Because really what I want is the physical separation. There is some 5% dextrose or weak dextrose solutions do actually calm down nerves. In fact, when people come into the ER and they're allergic to the anesthetics, we can sometimes use a sugar water solution next to the nerve that will give us some anesthetic. The short answer to your question, though, is it's mainly D5 with a little bit of lidocaine when I'm doing hydrodissection. If I'm doing a nerve block, I'll use all lidocaine, or if I want a longer action, I'll use all ropivacaine or some other long-acting anesthetic. Yeah. A similar question, what steroids or cortisone shots are things that people will ask me about on a regular basis as well, because once you can put a needle in a joint, you can put anything in that joint. Most people are familiar with the cortisone shot. I have cortisone in my cupboard. I don't use a lot of it because it's a little bit of a deal with the devil. If you put it into a joint or next to a tissue, it'll make you feel better for weeks to months, maybe 3 months, something like that. But it's known to be toxic to tissues. So if I put it into a joint, it can further degrade the cartilage. If I have osteoarthritis on my knee, I want all the cartilage I can get. You know, I've seen people get it in the sole of their foot for plantar fasciitis, which is a condition where you have pain right where you're right at the front of the heel. And if it gets into the fat pad on the bottom of the foot, it'll kill the fat pad. And your fat pad on your foot is your cushion. So it's a drag to not have, you know, to be missing part of that. There are times when cortisone works and when we do use it, but like I said, it's pretty, I use it once a quarter, just to give you an idea. It's very uncommon.
On everyone.
What's that?
On everyone that you see.
Yeah, total. Like all the patients I see, I'm working all the time, and I use it very infrequently. And it has to be. There's this really long, boring conversation that the patient has to have with me, like we're having right now. Just kidding. But that, where I try to talk them out of having it. So yeah, there's just better options. Yeah.
In terms of the diagnostics, like when someone comes in with regards to the functional medicine versus like, you know, sort of more acute pain, like how do you sort of tease out whether they have some underlying condition, or is it more you try to solve the pain issues first, and if that's not working, then, you know, look at the functional piece? Yeah,
I mean, it's kind of a mixed bag. Some people have a known condition, and then it's a matter of how well is it controlled. If usually when someone comes to me to talk about pain, we'll just talk about pain. And I'll ask questions, are you taking other medications? Have you had a workup apart from what we're already doing here? And sometimes that will flesh out some part of it. If I start hearing, if they come in for, say, the right shoulder pain, and their both hips and both knees hurt, and my neck hurts, and everything hurts, okay, well, maybe we should take a step back and run some labs and see if there's something else going on that would make it so if we do go down the path of treating you, that you would be better. Having said that, I have, and I can think of two off the top of my head, patients that come to me and they're like, I have Hashimoto's and it's not very well controlled. I'm still eating everything I want to eat and my numbers are out of whack, but I still have pain. So then the conversation is fine. We have things we can do. You'll do better if we do this in concert. But I'm happy to treat you. We just need to manage expectations. Like you and I both need to know that you're going to do better if you do this. But it's likely we can get you feeling better with what we can do. So, great.
I guess I have one. Like, how common is it for you to see patients who've been recommended surgery or are facing surgery be able to get away from having to get like a life-changing surgery with these treatments?
Yeah, it's a hard question to answer because the question is always what is causing your pain. If you've got a nasty looking hip on x-ray and the pain is primarily muscular, well, I can answer it that way. I have several patients who have terrible looking x-rays and they were told they needed a hip replacement, for instance. And I've been able to use the techniques that I've outlined to significantly improve their pain. So then is it that they're not having their surgery this year? They might have it in 3 years, but I guarantee you that that the person and I are going to try to make it so they can push it out even further, even further.
Yeah, that's basically what I was asking. Yeah.
But sometimes the answer is surgery. I'm not anti-surgery. I would just, nobody, even surgeons don't want to have surgery. If you need surgery, go get it. But usually we want to try a few things before we do that. Yeah. Some of my best days are though when we can make people not have surgery. And there are patients that I have that I mean, whatever, I've only been practicing for 5 years doing this stuff, but we're that far out and they're still not, they still haven't had surgery.
Yeah, okay.
I would say though, if you come to me and we work on you and we get you better or we don't get you better, we get you somewhat better and you're still having residual pain, the proof is in the pudding. If it didn't work, you're still having pain, go do everything else. You know, I'm not the answer for everybody.
Yeah.
And if it's not what I'm doing is not working, we're not doing it anymore. Go see somebody else. If it's a surgeon, fine. Hopefully not, but sometimes it is. Yeah. Awesome. Well,
Actually, I'm sorry.
Oh, absolutely.
So, have you encountered patients that come to you in their late 70s, early 80s that have had heart problems in the past that maybe their primary doctor says they shouldn't be on TRT and they shouldn't be exercising very much, and how do you deal with that conversation?
I don't do a lot of TRT. I know, I know about it, and I have, as I've mentioned, somebody that does that in my office. Testosterone replacement therapy. Yeah, thanks for asking. There are certain medical conditions that make it more dangerous to do aggressive exercise, Like the founder of SmartFit is a great example, right? But if someone's telling you don't exercise ever, that's probably the wrong answer. There are very few things on this planet that give you more benefit in health, all comers, than exercise, regular exercise. It depends on what type it is, you know, but yeah. I don't know if I'm answering your question, but if you're told not to exercise, I would ask a few other people, and I probably wouldn't listen to the person that tells you not to exercise indefinitely. Sometimes we say, you know, for this period of time, don't use this body part, or back off. Does that kind of get what you're asking?
Yeah.
Yeah. Guys, thanks so much for coming out. Appreciate it. Great.